Wonderful. Well, we are going to get started. We have a critical mass. I see Mayor Whaley has also joined us. We've got.
Sorry, I had a challenge with the link. Sorry about that.
No, thank you so much. Great. Well, it is my distinct pleasure to welcome you all to today's discussion on access and anti-racism and opioid treatment, what cities need now, hosted by the Boston University Initiative on Cities and the BU Center for Innovation in Social Work and Health. My name is Catherine Lusk. I serve as the co-director of the BU Initiative on Cities, and I have the pleasure of introducing our guests and moderator, and then I'll turn it over to them for the discussion. Together, they'll examine how cities and their allies can address systemic barriers to opioid treatment and protect the health and well-being of their residents. I'm delighted to welcome our panel of 4 terrific speakers. First, Mayor Nan Whaley, the mayor of Dayton, Ohio, who was first elected in 2013. She's been a longtime friend of the Initiative on Cities, and we're really delighted to have her with us. Mayor Whaley has been a leader in addressing the opioid epidemic, dramatically reducing overdose deaths in Dayton. She's a fierce advocate for federal and state resources for cities in her role as president of the U.S. Conference of Mayors and as a founding member of the Ohio Mayors Alliance. She's also now a Democratic candidate for the governor of Ohio. Drew Carpenter is with Bay Cove Human Services, where he works as a recovery support navigator and substance use counselor in their complex care program. Bay Cove is a human service organization supporting individuals contending with addiction, mental illness, and homelessness. Drew brings personal and clinical experience as a community advocate, health worker ally, and trained substance abuse counselor. We're also joined today by Dr. Miriam Kamarami, who serves as the medical director for the Graken Center for Addiction at the Boston Medical Center, where she leads programs to expand access to and engagement with care for patients who have substance use disorders, particularly those from marginalized patient populations. She's also a professor in the Division of General Internal Medicine at the BU School of Medicine. And finally, our last speaker, also a friend of the Initiative on Cities, David Rosenblum, a professor of health, law, policy, and management at the BU School of Public Health, where he focuses on health policy and issues related to substance abuse disorders. He has led research and national community-based demonstration projects in addiction prevention, treatment, and policy. His career has spanned public, private, not-for-profit, and academia. And finally, our moderator for today, I am so delighted to introduce Christina Lee, an associate professor with the BU School of Social Work and research core director at the BU Center for Innovation in Social Work and Health. Her research bridges intervention science, addiction psychology, and health disparities. Thank you so much to the speakers for taking the time to be with us today, and to all of you joining us in the audience. A reminder, today's webinar is being recorded and will be available afterward on our website and YouTube channel. Christina, over to you.
Okay, thank you, Catherine. Thanks to our audience and speakers for joining us today. We have brought this interdisciplinary group of experts together because we are now at a crucial inflection point. Specifically among Black Americans, the rates of opioid overdose rates are higher than other racial ethnic groups and is increasing. A study recently done by BU researchers has reported a 40% increase in the opioid overdose death rate between 2018 and 2019 for Black compared to white individuals. One of the conclusions of the report was that an anti-racist public health approach is needed to address the crisis of opioid-related harms in communities of color. We'll get back to this point in a moment. Second, on March 11, 2021, President Biden signed the American Rescue Plan, or ARPA, into law. What is unique about the ARPA is that the money is released directly to cities and not at the state level. We also have the Sackler settlement, which is intended to fund substance use treatment centers. So at this juncture, we find ourselves asking, with this opportunity and with this need, what can we do? So the goals of our talk today is to envision what an anti-racist public health approach to substance use treatment can look like that is informed by the experts on this panel and by your input. We're hoping to arrive at a recommendation for how to use the money in a way that is anti-racist that cities can consider. So we do want to hear from you. We want to hear your ideas and questions. Please put them in the chat, and we will go back to them at the end of our session. We'll give about 10 to 15 minutes for questions. So I'm going to, I'd like to kick off our discussion by first defining the word anti-racist. As we all know, it does not mean racism at the interpersonal level. Taking an anti-racist approach means addressing structural racism in the development and execution of policy, practice, and research to ensure that the gains from addressing the opioid crisis are achieved equitably. So, for example, most policies don't mention race, but because they're applied inequitably, they can result in health disparities. We can see that example of having a policy to deliver harm reduction treatment, like needle exchange for people in OUD treatment, but people in one zip code may get that those resources and not another zip code. So to begin, I just wanted to get start a discussion on the information or understanding the ARPA and the Sackler settlements a little better, and what that means for people in OUD treatment. So Mayor Whaley, could you explain to our audience what the American Rescue Plan Act provides for local municipalities, and why does it provide such a key opportunity for people in substance use treatment?
Well, thanks, Christina. I think the ARPA money that is first put to cities is the largest federal grant that we've seen ever in the history of Dayton, for example. The city of Dayton's portion of the rescue plan money is around $138 million. And for example, Cleveland is $500 million. It's one of the larger amounts. And it was decided, the funding code was decided mostly to help in legacy city areas through the CDBG formula. So I think it can be transformational for communities across the country on really trying to get investment in places that we've seen just a significant lack of disinvestment over the past 5 decades, really. So I think that, mayors across the country are being really thoughtful about how they're going to spend this one-time funding to make sure that it has, real systemic change and has real opportunity for our communities. When it comes to opioid use, the public health departments as well have gotten a lot of money for COVID. And what we've seen, we haven't seen this in Dayton, but we've seen this in cities across the country, particularly during COVID, is an uptick in accidental overdose deaths during the COVID pandemic, which particularly I think in 2020 we saw that rise pretty significantly. And the question really I think is it just from COVID, or are we just overall seeing more opioid use across the country, like Dayton was the tip of the spear on this issue back in 2014 and 2015. So look, I think what the ARPA money and other funding that you're talking from the settlements, et cetera, give communities a real opportunity to think about mental health and addiction services and mental health and addiction use and how we can really attack this disease. And that sort of funding doesn't come around every single day, but getting this opportunity to say, okay, because a lot, for example, in the state of Ohio, we have seen actually mental health and addiction funding from the state even go down, even during this period. And so this new funding sources give an opportunity to really invest in this treatment. The other point I'll make is for opioid addiction services, we notice in communities across the state that, the Medicaid portion is well taken care of, but there are pieces, longer term care, outreach to communities that have been hit that isn't funded through Medicaid. And so I think this ARPA funding can give communities that opportunity to invest in some of this more wraparound and longer term services that aren't funded regularly with our regular healthcare systems.
Thank you for pointing that out. Um, David, with regards to the Sackler settlement, can you explain similarly what that can mean for people struggling with addiction?
So, Dayton was one of the first, I think it was the fourth city nationally to sue the drug companies to hold them accountable for the epidemic that they brought on.
Wow.
And shortly after, I think I always like to say Chicago was the first city to sue. And shortly after, hundreds and thousands of cities followed in these drug suits. We have actually in Ohio come together to settle on some of these suits as a group. And so these settlements, I think, can give opportunity, particularly in Ohio. I think we've done a very interesting program where the cities have agreed to take a portion of the funding, but the other funding goes to a foundation to really deal with addiction services, and recognizing that this is never going to be enough money to undo the pain that the drug companies and pharmaceuticals put on our communities. But how can we have, and I think putting it in this foundation makes a lot of sense, because then communities and nonprofits can actually apply for this funding. So we make sure that it goes to mental health and addiction services. So the part that the city gets, the city is trying to recoup funding that they've had to do on ambulance runs and other parts of first responder services. But, I think the cities across the state were really smart in saying, yes, we're going to go in as a group. And we recognize that we need to invest in mental health and addiction services. And the only way to do that, to see new ideas and to see new solutions, was to put this money aside as a foundation, as an entire state and our settlements. So I think that's unheard of anywhere else. And, we are a state of cities. And so I think it says a lot too, that I think nearly every local community that sued came together and said yes to this. And I think our latest settlement's around $880 million for the state of Ohio. So that's a huge opportunity for us to really treat addiction like the disease that it is, to look for best practices. And, in Dayton, that's what we've tried to do on this issue. We have put together this comprehensive overdose action team, or COAT, which is a collective impact model. It has become a national best practice, on how to deal with addiction, and brings hundreds of groups together to really attack the opioid crisis. It's still active today. We've put this together in about 2014 or 2015, and it still moves forward. And I think too, we cut accidental overdose deaths in half in 2017 because of the work of the COAT. And what we have seen across the country, while like I mentioned, other communities have seen an uptick, ours has continued to level off. And I think that has a lot to do with this holistic approach and everyone playing a part in addiction and mental health. And then finally, recognizing we couldn't, jail our way out of addiction, and really looking at addiction in a completely different light. Now, I'll say, Christina, I wish, I was in high school in the 90s. We did this completely wrong during the crack epidemic. And the opioid epidemic gives us this chance to do it better. And as we see, I think what's important too, as we see an uptick across the country of people of color falling to addiction issues, and particularly around opioids and fentanyl, we cannot back down from this new way of looking about addiction and addiction services. And so I think, and treating it like a disease, that will be the biggest fallacy if we see this move back to a criminal justice model in our country. But we're really proud of that work here in Dayton.
Yeah, it sounds like it's quite a victory, and really gratifying to see that the money is being used so thoughtfully. I wanted to, I guess, ask, a little further, but what have you seen in terms of communities of color? What is that like, the programming that you've done and the innovations? How is that translated?
Look, I think what we've seen, the data has shown that the work that we did have impact on communities of color, but particularly did not impact women of color as much as any other group. And so we're still trying to figure out like why it didn't have the full effect. and doesn't have the full effect for women of color. This is why, we really need to have more tested messaging for opioid use, really understanding deeper about what moves folks in this and what will really change behavior. We did develop, new culturally appropriate messaging and materials to media avenues to really reach out to the African American community in our city. And we haven't seen a rise in any way in the African American community. What we've noticed with opioid addiction in Dayton and in Montgomery County is that it affects, the county's 80% white, and 80% of the people that died of opioid addiction were white, and 20% were African American. So it completely tracked with the population. So we noticed that early on here, that it was across the whole, and I think that gave us an opportunity, because it wasn't just affecting one demographic group, it was affecting every demographic group for us. And so then that allowed us to really attack it, since it was in every single pocket of our community. And it continues, even though we've cut accidental overdose in half, it still is the same percentage across the board. So we don't see any sort of movement like you're talking from across the country. Now, we recognize we were at the tip of the spear of this issue, so we have a different experience than others, and have attacked it in a really aggressive way because it was so difficult for us. But as far as our messaging, we noticed that women of color were the area that we had the least resonance with moving forward on it.
Okay. Well, what is impressive is the breadth of your programming and kind of the sensitivity to the different needs and getting the money there. And so this is a question, David, you're on the State Advisory Committee in Massachusetts, the Opioid Recovery and Remediation Fund Advisory Council. And I was wondering, what are your thoughts on how we can make sure that the money gets to the right places?
Well, I think that the members of the Massachusetts Commission are very interested in making sure that money goes to the communities that have been underserved. They're tracking the data very carefully and seeing the rise in opioid overdoses, fentanyl related, all of them, among African American and Latino communities, and they want the money spent there. The problem is going to be that the state processes that will start contracting for money are exactly the state processes aimed at exactly the existing state funded providers who have failed to serve these communities in the past. So if there is no structural change in the way in which the state actually bids out and provides contracts, my guess is that a lot of the money is not going to go to the groups that are being identified as needing high priority. And so I think that if you're talking about structural change, you're talking about changes in contracting procedures, changing in contractors, getting new contractors into the game. And cities in Massachusetts have not been in the drug treatment business for a very long time. And so they're going to need new partnerships with community groups. But mostly what they're going to need, in my view, is a strategy, a community-based strategy that really does target resources carefully and monitors the use. And I don't see that strategy in a lot of what has been the traditional state down use of these funds. The opportunity exists with these new programs, but there's no guarantee that that will happen if we rely on old contracting mechanisms.
Wow. Thank you for sharing that. That's a good question, I guess, for the speakers here, which is, how to come up with that strategy that is community informed and based. Miriam, you've been researching anti-racism practices in treatment at the Graken Center, which was created to be a hub for national hub for substance use treatment and best practices. What have you been learning?
Thanks, Christina. I think, we've brought together a pretty broad group of people from across Boston Medical Center, Boston University, and the neighborhood to try to look at how we can provide treatment for Black people who have substance use disorders that is more appealing and effective than what we've traditionally been able to offer. One thing that we realized pretty quickly is that just relying on the existing literature, the published literature, isn't going to get us there. When you look at, who are the editors of major medical journals, who are the people who mostly publish in major medical and sociologic journals, white men dominate those arenas. And so looking there alone for answers is kind of barking up the wrong tree. So we certainly want to acknowledge work that has been done in the past, but also acknowledge how important it is to go directly to the community and ask for input on what will make care more effective. And so as you know, we're doing a series of focus groups with folks, Black people in our communities who have issues with substances and can tell us about what they want and need from treatment. And I think we can extrapolate from that as well to how this money should be used. If it's the same old folks making the decisions about where that money is going to go, we're probably going to get it wrong. I think that's just a rephrasing of what David was saying, that we need representation of the communities that are going to be served in the decision-making process and the service provision process. One thought that I've had about something that's very important for us to do with these funds is it's really clear that Black patients, many Black patients prefer to have Black members of their treatment team. And yet we have relatively few Black treatment providers in addiction treatment. And so doing things to support the recruitment and training and help to ensure the success of Black individuals who want to go into addiction treatment is very important. Because of structural racism, a Black individual is less likely to have the capital to pay high costs of tuition, to be able to afford to do things like an unpaid internship that's often required for social work training. And so acknowledging that and targeting funds to support folks, Black and brown folks, to go into these fields would be a really productive way of starting to address some of the inequities we see.
Excellent suggestions. Thank you. Drew, you're on the front lines, supporting individuals struggling with substance use. Can you tell us a little bit about what communities of color, what they want and need to make it more relevant and accessible?
Yeah, thank you. First, I want to say, piggyback on what David said, changing the culture here, particularly in Massachusetts. If you're not from this state, you wouldn't know so much about the culture. The state is 65 to somewhere to 68% white. The state has always taken care of their own. When I mean by own, I mean by own. So the Blacks always got the short end of the stick in not just substance abuse areas, in all sorts of areas. So by that being said, we have to change that culture to saying people need help across the board. This is not a Black or white thing. This is a life or death thing. And what's happening here in this community is also happening in this community. As Maya said, it's happening in both states, up and down or whatever you have. But the thing is that we are not getting the facilities that we need in our communities to service the people in our communities. If you look, I'm right smack dab in the methadone mile right now, where there's facilities set up to help these individuals that's predominantly white in this area. They have access to food. There's a hospital there. There was a detox here. It shut down. There's shelters here. There's a treatment center. There's tents set up. We don't have that in areas that's in the predominantly Black community where there's a lot of use going on, particularly Nubian Square, the Grove Hall, deep into Mattapan, Fields Corner area, parts of Dorchester. So if we can get facilities to come on board, and I had a good discussion with David the other day about how they have reached out to some of these community centers in these public places to try to get them on board to have services there, and they were shut down. The other thing is important is education, educating the communities, educating the Black community on what's going on. We're out of the loop most of the times of what's going on. We're barely at these roundtable discussions. I was just reading in one of the Q&A, we're having a conversation about an African American woman, but yet we don't have one on this panel to give her view in how she may feel about how she's being shorted in services and for her needs. So I think that changing the culture, changing the mindset, like Marian said, of individuals. You can't have these same people with the same mindset trying to control this money, because it's not just going to reach us. They're going to have a mindset. They just really didn't care. Let's be frank. Let's be candid. I was part of I'm a recovering addict, by the way, almost 11 years clean, and I was part of the crack epidemic. And it was always criminal, throw them in jail, do this, do that. Wasn't no services and everything. But now we have this opioid epidemic, which is affecting the white community. Now we have people stepping up and says, okay, we got to do something about this. So we created this criminalization thing. There's less jail and there's more services. So boxing clinics are opening up. Methadone clinics are opening up. They're reaching out to people. Their outreach going into the communities and reaching out. Not saying that's being done in African American communities, but more so in predominantly white areas. So I just believe that, we're just getting the short end of the stick, and we need our community advocates and voices to speak up more about these things. I did a little research about what the Governor Whaley did when she granted the $115 million that was spread across the state to 16 different agencies. That's roughly $93,000 per agency. How are you going to get a short-term fix for a long-term, to try to get a long-term solution out of it? I don't know. This thing is ongoing. It's long-term. We got to go in with both feet, and we got to go hard if we're going to have any results. No one gets the short end of the sticks. Everybody needs to have an equal share in this. I mean, Black, white, everybody. We need to come together, come to a solution, and get it done.
I think you made a good point, Drew, and thank you for that. That was raised earlier, which is about how do we come together on this crucial issue. This is a moment in history, a one-time moment in history when we've got funds coming in, we've got awareness of the importance of involving the community and community voice. How do we connect, the community with the structural change that we need at the structural level? I guess that's my question for all of you.
Well, let me say, one thing we can start is by having these discussions, which is good. Now, we can have these discussions until we're blue in the face, but we need action. We need action. And until we put into place some sort of action, we're not going nowhere. Like I said to you the other day, let's start spending the money first and foremost. The money just sitting there. You know what I mean? Let's come up with let's get it out there. Some kind of way. Somebody needs to come and say, hey, I got an idea. Well, let's fund it. Let's get it out there. Let's see what it does. Let's see if it works, but having this money and doing nothing with this money is useless. You know what I mean? So having more of these discussions, bringing more people in who have access to facilities and things of that nature to get these things going. I just want to go back to what Miriam said about there's a lack of Blacks in this field. When I was an addict, active addict, there was a lot of Blacks around. there was just a lot, and they had the experience, and they was helping. But what happened is now we want all these credentials in play. We want this LAID Act, we want this bachelor's, and it's coming from people who doesn't have a level understanding of what an addict is or who an addict is. They have this school knowledge, but they don't have the street knowledge. We need that. You know, we need to identify with it. That's why I said the old model works so well. This new harm reduction is doing more harm than anything, in my opinion. That's just my opinion. Some of the things about harm reduction is great, but one addict can best understand another addict without parallel.
I think you're bringing it back to an earlier point about the importance of education and common understanding around what's happening in the addiction arena. David, you had said something earlier about changes in contracting procedures and maybe getting new contractors and finding new partnerships. Do you see any commonality with, with what Drew's saying in terms of bringing people to the table? I mean, what can that look like in a more, would that be identifying community organizations that work effectively on issues of addiction and bringing them into the fold, so to speak, to work with the state, the state funds? And
I think there's an opportunity with the settlement funds and the COVID relief money that's going directly to cities to create new structures to manage and allocate funds. And those new structures should include representative groups from all parts of the communities. That doesn't automatically translate into a new program. Coming together, these groups need to have a strategy. What problems are we trying to solve? Who else in town can help us so that you have an appropriate partnership? And what evidence-based practices are we going to put in place, and how are we going to keep track and hold people accountable? There's no magic to any of that. I think that one of the things that Drew and Miriam pointed out, and Mayor, I'd like your view on this, states and even municipalities tend to give contracts to community groups on very short terms. And the community group, therefore, is looking to its next grant before it's had an opportunity to spend this grant or actually be effective. And so I think that one of the opportunities we have is to invest long-term in the development of new community-based institutions that are more reflective of the people who need to be served. I think we need to invest in housing because I think there's substantial amount of belief and evidence now that stable housing may be the first key to long-term recovery in both substance use disorders and mental health. And the traditional treatment people, God bless them, they don't know anything about housing and don't care about housing and think that housing is taking money away from them. And so I think that we need to have some structural change in the decision-making process, but we also need structural change in strategy and in execution. And maybe the municipalities can get back into this business. And Mayor, I'd sort of like your view on this, but our commission has 10 members representing municipalities, and they're terrific. But the reality is they're not in the business, and they're going to need a lot of help to get into this business, and they're going to need some money to build local institutions that can be effective.
Yeah, I think David's right. I think the long-term funding piece is really a key point, and it's hard for local governments, particularly because of the unknowingness of their funding sources, that it's harder for them to think of a long-term solution on funding source. One of the things we have here in Montgomery County is we have a human service levy that is locally funded countywide, and so that funding source funds children's services, adult drug and mental health services, developmental services, all together as one levy. And that gives a funding source to mental health and drug addiction I don't think a lot of other local communities have. And that allows us to be more long-term in the partnerships of that work. And that's local funding for this work, which I think is very different than other places. I think, David, you're exactly right. The housing issue around addiction is very, very real. And there is very little funding in housing overall, much less housing with addiction services.
Mhm.
And I think that's one of the biggest challenge we see in really working on this issue is, this whole idea that 30 days and then you're good and you have it all figured out. It's just, everybody knows it doesn't work, but there's no funding besides really from local communities that really fits the bill for that. And I think that's a big issue if we're going to be really serious about addiction services overall. One of the groups that came to Dayton is a group called 115, and it's a sub company is Verily, which is Alphabet's health company. And they came to Dayton obviously because we were the tip of the spear on this addiction issue, but really worked to figure out a way to have all different types of care, no matter where folks were in the continuum. So they have acute trauma care all the way down to months and months of, inpatient services. And that does two things. Number one, it's not having the person that is sick with this disease fitting themselves into the treatment, but bringing the treatment to where the person is and how long the person needs. And secondly, obviously this company is interested in learning more about, the brain and what really triggers addiction, because at the end of the day, we really do at Dayton view this as a disease. And, and some of it we found can be genetic predisposed, and we don't know enough about addiction really at all. If you compare it to the disease of like cardiovascular disorder or, diabetes, we know lots about those diseases, but when it comes to mental health and addiction, we know very little. And we know so many people have an addiction disorder. And so really trying to dig into the science of this, I think is as important as, really trying to solve this challenge. It comes on both sides. I think that is the real challenge we have long term, is just how we think about it and how it's really funded. ARPA and the pharmaceutical money are one-time fund sources. They're not the long-term real understanding of how we really treat addiction like a disease. And, I know I've said that probably 5 times. I just think it is just so important that we just completely change our frame and mindset about what's happening with people with this issue.
Well, that's what I was making a statement about, helping these individuals in treatment and possibly giving them the tools to go to school and get educated. I went through the course at UMass through Mass Rehab to get certified in addiction counseling. And what I bring to the table is my personal experience. So I do understand the addict and the addict's mentality. Addiction is addiction is a two-component addiction. It's a mental obsession, a physical compulsion. But the understanding the mind of an addict is a totally different aspect. You know what I mean? You really have to get up and close and personal and get to knowing them and their behaviors to really understand what's going on with them, what they need as far as services, and where they need to go later on. And that's the point of helping some of these people get back into the field. I think it's such a leg up. It's such very important to do that. I'm not saying that you have to be an addict to understand the addict. I just said one addict best understand another addict because he went through some of those certain things. He or she went through some of those things, and they can identify and more so and explain to them, oh, this is what I did to get better. So let me offer this solution to you. Maybe it can help you, but not having that understanding and being baffled to why he or she continues to go back out that door and use drugs. You'll continue to do that to the rest of your life until you fully sit down or get involved on the front lines and really understand what addiction is.
Thank you. I think mentioning that, referring to the fact that addiction is a holistic disease and that, it affects all parts of people's lives, not just the medical condition, that the physiological dependence. And just thinking about the kinds of treatment options that people want in the community, which are not just about MAT or opioid MOUD treatment. So I was wondering, Miriam, in terms of some of the work done by Dr. Ayanna Jordan, kind of highlights at Yale University, highlights the importance of how treatment has to be tailored to target communities of color. And she's done a lot of work collaborating with faith-based communities in the churches, delivering treatment there, and in more obviously community settings. So I was wondering what your thoughts on such initiatives to help with this. Like, what is your perspective from the Grayken institutional?
Great, thanks, Christina. Yeah, Dr. Jordan's work is extremely inspiring. She's a really powerful, talented Black psychiatrist and addiction specialist who has established some great collaborations with Black churches in her area, and now in a larger study across the country, where she's looking at the impact of partnering with leadership of Black churches and offering treatment actually in the context of the church. So doing screening and offering treatment in a church setting. Part of the value of that, I think, is that the church is a trusted and respected institution, whereas healthcare organizations may not be for the general population, but specifically for the Black population because of the history of systemic and organizational racism. And so working with church leaders who can, in a sense, vouch for the importance of this and the validity of seeking treatment, her hypothesis is that will have a big impact, and her early studies have shown that in increasing people's willingness to engage with life-saving treatment. So I think it's a really exciting example of someone who's thinking outside the box and is really reaching to partner with community-based organizations, in this case, faith-based organizations, to leverage each other's strength and focus on this incredibly important issue.
Let me just add that I think that it's terribly important to have these kinds of valid community partnerships, but it's not really a but it's an and use evidence-based treatment. I think that the evidence is very clear that people with opioid disorders who receive medication treatment are significantly more likely to be alive years later than people who have an opioid disorder and do not get medication treatment. So it's a combination of medication treatment and other things, and the ability and credibility to work with appropriate community-based organizations is really very, very important. But the evidence says that medicine makes a big difference. And it's not an either or, but I think that we really need to make sure that, a development of all these partnerships, one of the structural changes is that we bring medicine into drug treatment in a regular and important way. And lots of the traditional approaches really were anti-medication, and frankly, in my view, are part of the problem.
I think that some of the brilliance of Dr. Jordan's work is that she's demystifying medication treatment, gaining the trust of church leadership, and then working with them to gain the trust of the community to have medication be really the cornerstone, but also incorporate
I think that's right.
cultural
I think
and
that's
social
exactly right.
support.
Yeah, I think that's exactly right.
I think there's a lot of misconceptions.
Also, I just want to interject. We have to remember this too, if we can, that, medication plays a big part, but medication is not the overall solution. And we don't want to just put all our eggs in the basket on this one. For instance, a lot of people I know, my predecessors that are in treatment, the 12 steps, the simple traditions, 12 and 12 steps, help me recover from my addictions, from drugs and alcohol. No medication could do that, because it's not. It's just the drugs and alcohol are what's the word I'm looking for? Or just a symptom of the disease. Okay, let's get that first and foremost. The drugs and alcohol is just a symptom of disease. Why do an individual want to stick needles in their arm, drink a bottle all day long, or smoke crack all day? That comes into the mindset, the belief system. What's going on with you? Have you experienced some traumatic experiences when you was young? Let's get to the exact nature. And the steps are designed to help a person solve those issues and have longevity in treatment. And what I'm hearing and what I've been hearing is getting away from the 12-step model and getting more into the medication thing. And, and who's benefiting from it? The addicts are not benefiting from it. I know addicts that have been on methadone for 20, 30 years. It's not for long-term treatment. That's not what the medication is about. The Suboxone, they're abusing the Suboxone, whether they're selling or using them. That's not the solution. The solution is treatment. Treatment, talking to them, educating them, reading. That's where treatment comes into that. And it's going to be the service to everybody, black, white, or indifference, if we don't get back to that. Medication is not the cure-all. It's not. And I tell addicts every day, everybody's making money off you but you. Drug dealers, pharmaceutical companies, insurance companies, we on this panel, everybody.
I think we can agree certainly that, go ahead, Miriam, were you going to say something?
Sure, I just will respond
Sorry.
briefly. Drew, I understand your frustration, and I do think it's a mistake to frame medication as the whole answer. Clearly, people need to learn a lot of skills to cope with uncomfortable and damaging emotions, to deal with trauma, to deal with co-occurring depression, anxiety, etc. The evidence is pretty clear that medication is life-prolonging, that the single thing that we can do that is most likely to have an impact on prolonging someone's life if they have an opioid use disorder is to offer them medication treatment with Suboxone or its generic cousins, or methadone. I share your wish that the medications didn't need to be long-term. Unfortunately, I think studies have shown pretty clearly that the medications are really helpful to help people avoid relapse while they're taking them, but that many people will relapse after they stop. So I really encourage my patients, if they're thinking about tapering off the medications, to make sure that their life is much more stable than it was when they started the medications, to be really sure that they have the supports to help them, whether it's spiritual, family, volunteering, et cetera, and 12-step, as you said.
I appreciate the discussion. I think we're ending on the right note, which is kind of the importance of really centering all of this on the experiences of people in the community around recovery, and how many facets, how many different things we have to consider. The questions, I'd like to spend a little time on the questions we're getting in the chat. And they're focusing on, again, the emphasis of this, the importance of this perspective. One question that came up was for Mayor Whaley around the foundation that she mentioned that you were able to create. Did that have a community advisory board made up of people who are actively using drugs or in self-identified recovery?
So the community overdose action team, yes, it did have people in the group that have been in recovery. It had almost 200 different groups, and it still does across the city. So that's a key part. We didn't get a chance to talk about some of the other actions we did with these grow teams, where and we continue it, but through the height of our epidemic, we would have a number of folks that would call 911 for an accidental overdose. And the next day, the police, one police officer and an EMS worker and someone that had been in recovery would come to their door to offer help and services that day. And I think the person that who was in recovery was one of the most helpful folks to get people to say, okay, I can do this. The key for us was to make sure that we had, a treatment available, right? We didn't not build up the pipeline at that time to, have the treatment available right then and there, because you can't tell someone, oh, okay, great, you're ready today. How about you wait 30 days? And so that was a key part of the building out of our system that had to be done in 2016 and 2017. It was critical to us stemming accidental overdose deaths. But yes, they're a key part of it. I work a lot with former mayor and now Secretary of Labor Marty Walsh on this issue with the U.S. Conference of Mayors, and we co-chaired a task force, particularly around opioid use and addiction use. And and Drew, I hear a lot of what you're saying, because as Mayor Walsh makes no bones about the fact that he is an alcoholic, and his look at addiction issues is very different than mine because of his personal experience. But what's also been interesting to me over the time I got to work with Mayor Walsh was how his perspective changed on the issue as well. And so I think one of the challenges too in all of this work is when you have gone through addiction and have recovered or are recovering, it's very personal to that person. And it's very easy to be like, this is my experience, I know my experience, which of course you do. What I've found in addiction issues is just how diverse the experiences are, and how difficult that is, and how little we really know about this stuff, because of the diversity of experiences that really drive addiction, and what moves people into recovery. And I think I just feel like we're just starting this work, both from a hard science side and a social science side. And, getting the community's mind right about it is so important too, because, I have had people in my community say, my brother is an addict, and if he was on my front yard, I would let him die. That is the frustration, just the sheer amount of frustration that members of the community and family members can have with just such a tough disease. And so we have, tremendous amount of work. I feel like we've just really started in this work over the past couple decades.
Thank you, Mayor Whaley. I'm looking, there have been some great also suggestions for in the chat. One of those include, and this is for everybody, how interrelated services, including housing, food services, and mental health, can be integrated into a funding plan. Another suggestion is there funding to help people become peer navigators, peer recovery specialists, especially among people in the Latina community, who might be able to provide recovery services in different languages.
Yeah, that is clearly an appropriate use of the money.
Money to train people to become peer recovery specialists?
Yeah, it'd be peer recovery specialists, or throughout the entire treatment spectrum. And so I think that using some of this money to train a new workforce that is more culturally attuned to the patients they're going to be treating is an appropriate use of the money. The pressure is to get the money out on the streets right away to help people currently in need. And so there's always going to be those two pressures against each other, but surely this is an appropriate use of the funds. So I'll just ask this question because I know that many people will have this, but if they were to seek this money, what's the pathway? Like, I'm thinking of a grassroots organization or people who
work with communities of color, how could they step up and get involved with the funding?
Well, I think the honest answer is that if they have no experience in government contracting, whether it's at the state or the local level, that they need to partner. We need to use money from these settlement funds to provide technical assistance, to assist new organizations to become eligible for state and local contracting. And they need to partner with groups that do have these experiences so that together they can move forward. But I think that freestanding community-based groups that do not have a track record and do not have access to technical assistance to get the track record and skills that they need are going to continue to be left out. And so I think that, again, we've tried to say this at the advisory committee in Massachusetts, some money needs to be set aside to provide the training and technical assistance and continuing support to get new actors into these programs.
I do want to say another thing, that we need more facilities opened up. Through the course of the years, we lost facilities to lack of funding, whatever the case may be. And I work at, on the front line, and it's disheartening. I'm at work at a detox, and I get a call, and we can't take you because we're full. How are we going to help this person? This person is trying to reach out for help, and he can't even get a bed for himself to get help. So he or she's going to go back out there and do what they do. So let's get facilities open. You don't have to come up with a decision on, where we're going to put this facility at. Put it somewhere. They're going to call. They're going to come. Whether it's in the Black community, white community, it doesn't matter. Let's open these facilities. And that goes back to what I was saying. Let's spend this money. And when we're having these talks and this money is not being spent, facilities are not being open, addicts are dying.
Thank you. I know we only have a few more minutes, but I just wanted to give an opportunity for our panelists to say any comments or no? Okay. Well, we've talked about a lot of different ideas in moving ahead, and I think the idea of more facilities, given that many have been closed, is very important. Also considering partnerships with community organizations, and many of the things that are being done, exciting things that are being done in Mayor Whaley's office and tenure. So I think that this issue is there'll be continuing conversations about this issue, and I'm hoping that they can be, interprofessional or interdisciplinary, because that is the nature of addiction, to best treat patients. So I want to thank you all for your time during this talk.
Thank you. It was a pleasure.
Thank you. It was a pleasure.
Thank you, Mayor.
Thank you, David.
Drew. Great to see you.
David.
Great seeing you.
Bye, everybody. Thank you.
Mary